Thank you. Last time when I was given a talk, the talk was Candida auris, the new kid on the block. This time, I'm the last kid on the block. So let me try to show, let me try to keep you awake. The prior two speakers spoke on polymyxin and Astrianum avibactam, their advantages and disadvantages. So I was asked to balance. I don't know how to balance. So see, balancing is more of an art than a science. So you can see how Bobby Daly is balancing there, and it's no science much in it. It's an art. So essentially, choosing whether polymyxin or Astrianum avibactam is more of an art. Not one size, not one underwear fits all the sizes. So just like that, not one drug fit all the sizes. And one of the key important thing is we need to take our epidemiology into account and then take the decisions. Now, so how do I balance? So for me to balance, I need to understand the current susceptibility data, which is pertinent to my country and which is pertaining to my hospital. Now, keep an eye on concerns regarding emerging resistance mechanism. Now, lots has been shown about polymyxin and ceftazidime avibactam, but we also need to keep on the emerging resistance mechanisms, especially to our Astrianum avibactam. Now, understanding the pros and cons of both the drugs, there are pros and cons which I am going to show, and taking local epidemiology into consideration. The most important thing, what your hospital antibiogram says, what particular ICU has what bugs, and how do we choose it. So taking syndromes into consideration before choosing the empiric choices, that is whether you're dealing with a HAP syndrome or a pneumonia or a CLABSI syndrome or a UTI syndrome. And most important is one size doesn't fit all. So this is how I'm going to balance, and I'm going to show you how I'm going to look into this. So the first thing is, first let me understand the susceptibilities. So this is the E. coli versus Klebsiella susceptibilities. Of carbapenem resistant E. coli and Klebsiella susceptibilities to your ceftazidime, Astrianum avibactam. If you see there, for E. coli, out of 117 isolates, this is from the CMC Velour study, the most worrying thing for me is that Astrianum avibactam resistance is up to 30%. And this is the, study, these are all done around, 7 to 8 months back. So already now you have Astrianum avibactam susceptibility is only 70% and 30% of them are resistant. So this is something you need to keep in mind. The reason for the resistance is the presence of penicillin binding protein 3. See, your avibactam inhibits OXA48, your Astrianum take care of NDM, but the organisms have become smarter. Now the issue is the penicillin binding protein 3, and mind you, now already you have 30% resistance for E. coli against Astrianum avibactam. But whereas you see the Klebsiella, at least we are lucky in Klebsiella, Astrianum avibactam works in up to 96% of the patients, and only we have around 4 to 5% resistance rate. But already I started seeing resistance to Klebsiella resistant to Astrianum avibactam. Now we already are in that particular era now. Now coming to the Pseudomonas. See, mind you, Pseudomonas, the mechanism of resistance to carbapenem is not only the carbapenemase mediated, it is also through porins and efflux pumps. So that's the reason for all our carbapenem resistant Pseudomonas, most of which are metallo-beta-lactamase, only 33% of our Pseudomonas isolates are resistant to Astrianum or only susceptible to Astrianum avibactam. Now, this is about E. coli, Klebsiella, and Pseudomonas, where already you are seeing creeping up of the resistance in Astrianum avibactam. And you all know that I'm assuming that for Acinetobacter, obviously Astrianum avibactam doesn't work because it is mainly mediated to the OXA23-24 mechanism of resistance. Now let me show you the colistin susceptibilities. This is the ICMR data. The E. coli the reason I did not show the Astrianum avibactam susceptibility in ICM because they did not mention, so I have to take other data. So if you see the E. coli resistant, it's only less than 1%. So colistin works in more than 99% of the cases for E. coli, and Klebsiella also the resistance is only less than 1%. So here also it works in more than 99%. And Pseudomonas also, the resistance is less than 1%. So Pseudomonas also works in 99%. So, and Acinetobacter, you clearly know that Astrianum avibactam doesn't work because mechanism is OXA23 mediated and NDM together. And here also the susceptibility to colistin is 99%. So here, we should come out of the mindset that, Astrianum avibactam is, is the way to go, E. coli, Klebsiella, and the colistin is the other way around. But again, you have the role for colistin. That's the reason I said it's a balancing act. It's not that one drug is preferred over the other. Now, so what are the pros and cons? See, if you see the Septastrianum avibactam, it is proven to be superior to polymyxin based on the combination, based on the all that is shown, already been shown. It has an advantage, also covers Stenotrophomonas and B. capacia, because we are talking about empirical choices where it's not only the E. coli Klebsiella, we do have even Stenos and B. capacious, and the most important provision is not nephrotoxic. Now, coming to the cons, what are the problems with that? So it doesn't cover your carbapenem resistant Pseudomonas and Acinetobacter. The coverage is poor. So this is where we lack the spectrum. Next, the synergy. And we all been, till recently we've been only checking for the susceptibilities. We're not doing the phenotypic susceptibilities. We are doing the genotype, and we are happily using Casavi-Astrianum, assuming that it will be working. As I told you, now we have penicillin binding protein 3. Already the Ceftazidime avibactam, Astrianum avibactam is already resistant, because we don't have, because synergy testing is showing, and we should do synergy testing. And E. coli, as I told you, mutation in penicillin binding protein 3 lead to the resistance. And even the Klebsiella, because of outer membrane protein and 35, 36 and variant AMP-C producers, you already started seeing resistance to Astrianum avibactam. So how do we balance? So this is how you need to balance. So it's the syndrome. You need to see which specific syndrome and where I need to use is the way to go. Now, sorry, this is VAP, or for example, if you see VAP or HAP syndrome, if your ICU, for example, my ICU, liver ICU has only Klebsiella is the predominant. So in my liver ICU, my empiric choices were VAP, is not coli. It's based on, because my liver ICU has all Klebsiellas. Here, Astrianum avibactam is my empiric choice. So this is how I would choose. Now, if I have one more ICU in my hospital where Acinetos and Pseudos are also concerned. So before I know what it is, I'm going to start this patient on. When I have a patient in this particular ICU has HAP or VAP, colistin based combination is I am going to use, because in that particular ICU I have Acinetos and Pseudomonas along with the Klebsiella as a concern. So this is how I would choose. One simple thing I would choose is that I will use the film array PCR and see if there is no Acinetos. I'm going to give a stat dose when I suspect it, check the PCR and see if there is no Acinetos Pseudo, then I will be comfortable with using Ceftazidime avibactam Astrianum. So this is how we should do it, not that one size fits all. Now, for example, it's a catheter-associated urinary tract infection. In my hospital, it's E. coli Klebsiella. And if you don't have PBP3, that means if your Astrianum avibactam resistance is not high, then it is Astrianum avibactam. In my hospital, we don't have PBP3 mutations of much. In my hospital, I'm still okay using Astrianum avibactam. But the same Cauti, if I manage in my bone marrow transplant setting, where I have Pseudomonas is also a significant concern, or in the ICUs where the Pseudomonas is a significant concern, I'm going to use as an empiric therapy, colistin-based combo therapy. Once the cultures are back, and if it is Astrianum avibactam, if it is not Pseudomonas, and if the other thing which is sensitive to this, then I'm going to target it accordingly. The same is with the bloodstream infection collapses. The E. coli Klebsiella, if it is no penicillin binding protein 3, is not a concern. That's the reason I'm telling you should know your hospital susceptibilities before using this, because gone are the days we're going to use happily Astrianum avibactam. And if you have a concern of having a Pseudomonas, then you're going to use colistin based combination therapy. Now, you have other places where you can combine both also. It's not like this or that. Even in certain areas, we combine both also. For example, if I have a patient who is in septic shock, or if the patient is really sick, because the data says that using there is certain retrospective using Ceftazidime avibactam is associated with better mortality. So, you can combine, because you don't know the bugs. It can be Acineto, it can be Pseudo. If the patient is in septic shock, I can't rely on one particular drug, because if my pretest probable, if the bug is wrong and the mortality goes up if the patient is in septic shock. So septic shock, if somebody is in the prolonged ICU where I have a concern for steno and BK patient, if the patient is for 30 days in the hospital, already received colistin and all, you can have even stenos and BK patient, and exposure to other carbapenem resistant treatment drugs. After sending appropriate culture, I can use even the combination therapy till I know what it is, and then once the cultures are back, and that's how I'm going to optimize. So this is how I'm going to use this particular drugs based on my local antibiogram, based on the local susceptibility patterns, and then I'm going to take the decision not based on Western recommendations or based on the overall things. So in summary, most important thing is to know your hospital ICU antibiogram, know the common VAP, COTI and CLAPSI bugs in your ICU and the sensitivity pattern, and also please do the phenotypic drug susceptibility results of Astrianum avibactam for E. coli, Klebsiella and Pseudomonas, because of the increasing resistance of E. coli and Klebsiella to this particular drug, and choose the appropriate regime considering all the above factors. I think taking into all, we need to consider these and we need to take decisions. I think thanks for the patient listening. I would like to take questions if any, please. Thank you.
Thank you, Dr. Vishnu, for this balancing. So, any questions from the audience? If no, any questions? No question, then I'd like to felicitate Vishnu. Please stay in the stage. I'd like Dr. Madhav, please come on stage. Vishnu, kindly felicitate Dr. Madhav. Dr. Mona Lisa, madam, you will please be on stage. To felicitate chairperson, I like Dr. Deepak to give a moment to Dr. Vishnu. For further proceeding, I will like to hand over stage to Dr. Bhavani sir and Dr. Deepak.
Uh, Thank you, everyone. I think we had a wonderful 2 days of academic feast. In fact, I was so absorbed in it that we lost track of the time also. So we have so much pressure. So much awaited validatory function will be there now. Uh, the flow would be we'll be having couple of awards for the best paper presentations as well as best poster presentations. Also, we'll be awarding the Professor Manimala Rao annual award for the best outgoing IDCCM student. Sir Bhavani sir. I would invite all the EC or present EC to come onto the stage, please. Also, Venkat sir, National EC. Come, sir. So, also, I think with very grateful for Dr. Srinath and Dr. Adarsh, as well as Dr. Prashant, who have been there with us. Prashant, Srinath, for the abstracts committee coordination. Can you come on to the stage? So they stepped up, they were invited. Uh, Adarsh and Srinath, yeah. So now we'll be announcing the prizes for the best paper presentation. Adarsh, you can announce. You can. First. So the best paper presentation was done by Dr. Vivekanand from AAG Hospitals, Hyderabad. The paper was on comparative analysis of CRRT, plasma exchange, and standard medical therapy in management of acute liver patients. Dr. Vivekanand, can you please come on? I would request Bhavani sir and Venkat sir to present the memento. The second best paper was validation of airway care score as predictor for successful extubation in neurointensive care patients, done by Dr. SVNLK Veni Nanduri from KIMS Hospital. The best poster presentation award was for Dr. Sai Tejaswini from KIMS Hospital. She presented on case of acute demyelinating encephalomyelitis following HPV virus vaccination. Anand. The second best poster was for Dr. Bharatram from Apollo Hospital, Chennai, on prediction of progression of acute kidney injury, signs more than ART. If Dr. Bharat is not there, I think would move on to the most awaited award, that Professor Manimala Rao Award for Best Outgoing Student. Kilani sir, can someone from behalf of the student can come, Dr. Shweta? Aditya? Yeah. So Dr. Shweta A was awarded as the best outgoing student from the Hyderabad.
Person. This award could only be possible with the support and guidance I have received from my mentors and teachers. This is not a recognition just for me alone, but it's a huge motivation to all the students who strive hard to achieve success. I thank ISCCM Hyderabad chapter for such a great honor and motivation. Let this set a reminder to me that every step forward makes a difference in my life. Thank you all. Good morning, everyone.
So Aditya, can you please accept the memento on behalf of Dr. Shweta? Dr. Aditya is a teacher, as well Kaladhar is another teacher. I would request all of you to please come for the group photo before we close the ceremony.